We have to say it, finally there, the last fifth of the short videos addressing axillary nerve as well as dermatomes of the upper limb. So let's not waste too much time. We know that axillary nerve is fairly simple structure, perhaps the simplest of all nerves coming from the brachial plexus, originating from the posterior cord, carrying only fibers of C5 and C6. One interesting area that we have to address is so-called the quadrangular space through which, like a thread in a needle, the axillary nerve must pass through in order to reach two muscles it innervates, one being rotator cuff muscle, teres minor, the other one being pretty much the most significant muscle of the shoulder, the deltoid. There will be also some interesting clinical scenario relevant to axillary nerve that we call the military patch sign, but more about it just in the next couple of minutes. Let us go now to Netter's Atlas and let's find out some information about the quadrangular space, which is perhaps the only complicated thing that we need to know about the axillary nerve. Here it is. It's the same diagram that we used to follow up the main trunk of the radial nerve, but this time our focus is just a little bit more superior. As you can see here, that is the quadrangular place in space. Let's just try to zoom in a little bit more so that the picture is at least having more appeal to you who are watching it on YouTube. Obviously, this is the teres minor, and the muscle inferior to it is teres major. Really, like a gap between these two muscles is quite negligible, where again, additional two sides of this quadrangular opening are generated by shaft of the humerus and the long head of the triceps brachii muscle. So essentially, it is like a little square through which axillary nerve comes to the posterior side relative to shoulder joint. Here are branches that it gives into teres minor, and here are branches that are coming into the deltoid muscle. One branch that you can see here being directed superficially, subcutaneously, is the superior lateral cutaneous nerve of the arm that will be related to what we already indicated, military patch sign. So, what is going to be a problem with a quadrangular space? In anatomical position like this, certainly the space is quite fine and the nerve is not compromised. But if the arm goes into abduction, basically both teres minor and teres major will come much closer to each other, so would come humerus to the long head of the triceps. So practically it is going to result in something that I can only use my fingers to try to identify. So between my two hands I've created a space which looks rectangular. Now when I change the position, I force some of the structures to come closer together, and as they do so, basically the space becomes restricted, and at that point axillary nerve eventually could be damaged. Fortunately for most of us, this is going to be just a very remote possibility, and if the injury to axillary nerve happens, because it could be a consequence of blunt injury to the back side of the shoulder, it could be a consequence of any penetrating injury, which unfortunately could affect the main trunk of the axillary nerve, a problem is going to be quite obvious. Deltoid muscle, if it's completely paralyzed, will really make a huge loss. Also, it will go into fairly quick atrophy, so contour of the shoulder might be completely lost, and now I'm kind of really trying just to fake it in front of the camera, saying this is the affected side, this is the intact side, so you can see immediate difference right versus left. So I don't have it, it was just for need of this recording, but wanted to give you at least some kind of visual experience. What would it look like if one side deltoid is completely wasted? Also, patient may have a little bit more pronounced internal or medial rotation because the loss of teres minor being one of the rotator cuff muscles, but being also external rotator. Its paralysis allows internal or medial rotators to dominate a little bit more and to force the arm in an unnatural position. The next thing that we need to say a few words about, and I would be using Netter's Atlas just to show you the pattern of innervation, and I have the diagram ready, so let us go here. Obviously, this diagram was also used to identify sensory innervation by radial nerve and its branches, but that is superior lateral cutaneous nerve of the arm, branch of the axillary nerve. Please note it is practically the lateral shoulder, and as such, we're talking about loss of sensation practically here where my hand is, and that is why it's called the military patch sign. Folks, elsewhere in the world, if you're watching this video, just to let you know, some uniformed people do have patches that are stitched on the sleeve, on the side of their jacket, on the sleeve. That is the military patch we're referring to. If uniformed people in your country are having epaulets on the top of their shirts or jackets, and this is where they have their insignia, like airline captains and co-pilots and flight crew, basically that's a huge difference. So if your perception about military patch is here, it's wrong. It's actually here on the side of the shoulder. All right, so let us take a look and find quickly few diagrams that will help us identify some dermatomes of the upper limb. It won't go too long until we get there. So I apologize for switching to different camera, but at least I didn't irritate your eyes flipping through several images. This is from the Netter's Atlas, and this is anterior view, whereas the next diagram is the posterior view. Well, this is what I really wanted to see it first from a posterior direction. Obviously, dermatomal chart looks a little bit more neat, a little bit more sorted out, just as expected, C3, 4, 5, C6, C7, C8, T1. Essentially, dermatomes are is a patch of the skin innervated by a single spinal nerve. So when we say this is C6 dermatome, that means regardless which peripheral nerve brings the fibers to innervate this patch of skin, actually it must came from the C6 nerve. And of course C7, C8, T1. Following it all the way to the right side of the screen, where we want to eventually see fingers, you realize that C6 covers the thumb, C7 covers middle and index finger, while C8 dermatome is entirely involving ring and little finger. So my emphasis here is that you really have to say, okay, there is a huge difference when you see dermatomes versus median or ulnar nerve. Should it be either median or ulnar nerve, their demarcation line will cut across the length of the ring finger. And because this is C8 dermatome, now you can ask yourself a question. How is this possible? Shouldn't ring finger be split medial and lateral half? No, because both median as well as ulnar nerve carry C8 fibers. So it is no surprise that C8 fibers of the median nerve are innervating the lateral side of the ring finger, while C8 fibers carried by ulnar nerve cover the opposite side of the ring finger. I hope that this was good exercise, that you actually can now start seeing and feeling a little bit of a difference between what is the dermatome versus what is the patch of skin innervated by a single peripheral nerve, whether it's a part of brachial plexus or not. On the anterior side, things look a little bit less idealistic because you see here C5 in yellow color, next to it T1 dermatome. Obviously, I'm glad that we have seen it on the posterior side first, because here is the C6 covering posterior lateral aspect of the arm, forearm, as well as going into thumb. C7 dermatome that we have seen also here covers posterior aspect of shoulder, arm, forearm, dorsum of the hand, and dorsal aspect of index, little finger. So this could be partly carried by a radial nerve for posterior arm, forearm, dorsum of the hand, but we know that distally it is going to be median nerve that will cover even dorsal aspect of index and middle finger. But the whole point is median nerve also carries C7 fibers, so we're not confused by this any longer. Here comes C8 dermatome, posterior dorsal aspect of the arm, forearm, and going into ring and little finger, whereas you can see the distribution of dermatomes over the hand in the same form. C6, thumb, C7, part of the palm, index, middle finger, C8, ring, little finger, and medial side of the palm. So if we follow C5 and T1 dermatome, we can say that they cover anterolateral and anteromedial aspect of the arm and the forearm. But interestingly enough, both C5 and T1 dermatomes do not reach the hand. Practically, they stop at wrist. So I think that this would be quite good, although I try to make individually these videos as short as they can be. If you try to watch them all in one day, I believe that we cover them in excess of 1 hour in total. So review of the brachial plexus was first, and then we went individually musculocutaneous, median, ulnar, radial, and now finally we're completing it with axillary nerve and dermatomes of the upper limb. I hope you really enjoyed this. Subscribe to Anatomy Made Simple by Dr. T. Thank you. Stay tuned. More anatomy-related videos to come in the near future. Bye for now.